Okay, let's get started. It's 12:02. Hello, everyone. Thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Eleni Sofrati, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Today, I will be presenting a case together with our guest speakers, who are Dr. Sergio Viana, Dr. Angela Tinga, and Dr. Dorota Linda. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community, consider registering on the OCAD website. This session will focus on infection. The speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, we will respond to them. Just a quick reminder, as I say every month, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for understanding, and with that, I'll kick off the session.
Okay. Thank you, Eleni. I have the distinct pleasure to introduce Dr. Eleni Sofrati, who is a practicing radiologist and is the medical director at MedScan Lagos. She graduated with a degree in medicine from Federal University of the state of Rio de Janeiro and a medical residency in radiology and diagnostic imaging at the Fluminense Federal University and a PhD at the Federal University of Rio de Janeiro. Since December 2020, she's the president of the Radiological Society of Rio de Janeiro and an advisory board member at Medscape. She's authored and co-authored original research and book chapters in MSK radiology. And since 2019, she's one of the coordinators of the MSK Image Group of Rio de Janeiro, helping bring education and partnerships between Brazilian and international radiologists, such as us, such as this MSK presentation series, which is a partnership between the Radiology Society of Rio de Janeiro and OCAD, one case a day. She's very involved in MSK radiology education, having presented at national and international conferences. She's interested in all areas of MSK imaging with an emphasis on rheumatology, infection, and diversity, equality, and inclusion in MSK radiology. Okay, Eleni, you're on.
Thank you, Hilary, for the kind introduction. I will share my screen. Can you see it?
Yes.
Okay. So this case is about a 17-year-old female patient presenting with fever, asthenia, low back pain, dysuria, and choluria for months, worse in the past 2 months. The symptoms started in December 2021 with asthenia and low back pain. In the following months, the symptoms got worse. And in February, she noticed that her skin was yellowish. And in addition to that, multiple skin lesions appeared all over her body. She also reported dysuria and choluria. So in March, she was admitted to the hospital and started complaining of swelling and pain in her right shoulder. So on physical examination, there was jaundice, multiple skin lesions, some of them infiltrated and ulcerated, and hepatosplenomegaly. So this was her face when she was examined, and these were the varicose ulcerative lesions on her face. Laboratory findings showed normocytic, normochromic anemia, leukocytosis with eosinophilia, elevated ESR, elevated ALT, AST, bilirubin, alkaline phosphatase, and gamma GT. And also she was HIV negative. So her radiograph of the shoulder showed lytic lesions on the acromion, clavicle, and in the proximal humerus. On ultrasound, there was a collection in the anterior part of the shoulder, in the clavicular part of the deltoid muscle, and also she presented with intraclavicular lymph nodes, lymphadenopathy. On MRI of the right shoulder, we were able to see okay, I think I missed one here, just a second. Okay, no. No, it's correct. Okay. MRI of the shoulder shows bone marrow edema-like signal intensity and enhancement of the distal clavicle and acromion with fluid and synovial thickening. Within the acromioclavicular joint with extension to the subacromial bursa and to the soft tissue surrounding the acromioclavicular joint. Enhancing fluid collection within the clavicular portion of the deltoid muscle were also observed. Here again, we can see the bone marrow edema-like signal of the enhancement of the distal clavicle and humerus and acromion, but also we can see this subtle lesion at the proximal humerus that was already visible in the radiograph. And also this patient presented with lymphadenopathy, infraclavicular and also axillary. Well, she also underwent MRI of the spine, and we've noticed this lesion in the sacral ala. And also, and it was in this lesion enhanced with contrast. And there were other lesions in the sternal manubrium and also in the spinous process of two dorsal vertebrae. And these lesions also enhanced with contrast. Okay, so case history summary. We have this 17-year-old female patient presenting with fever, asthenia, low back pain, right shoulder pain, dysuria, coluria for the last 4 months. And from the MSK point of view, imaging shows signs of septic arthritis of the AC joint with bone involvement, indicating osteomyelitis, and rim enhancing fluid collections within the deltoid muscle, and also infraclavicular and axillary lymphadenopathy, ill-defined lesions in the proximal humerus, right sacroiliac, sternal manubrium, and spinal processes. She also underwent a chest radiograph that showed bilateral mediastinal lymphadenopathy. And on chest CT, there was multiple small nodules with perilymphatic distribution, ground glass opacities associated with peribronchovascular consolidations. Mild bilateral effusion were also noticed, and lymph node enlargement. An abdominal CT was also performed, and we can see hepatosplenomegaly with denotation of intrahepatic bile ducts, predominantly in the right lobe, and heterogeneous splenic contrast enhancement. So for the differential diagnosis, the differential diagnosis for a systemic disease like this involving multiple organs is vast, including infection, tumoral, and other causes. And a skin lesion biopsy was performed, and the diagnosis was Paracoccidioides brasiliensis. So this is these photos here are from the literature, and it shows a similar skin lesion in which this fungus was identified. So the fungus are those black dots here. And fungal cells are stained in black, and some of them are in active multiplication. I don't have these photos from our case. So paracoccidioid mycosis is a systemic granulomatous disease caused by a dimorphic fungus, Paracoccidioides brasiliensis, usually found in South America, as you can see here in this map. There are two clinical forms of the disease: acute, subacute, which accounts for less than 10% of the cases, and the chronic form that accounts for 80 to 90% of the cases. Osteoarticular involvement is rare and most commonly found in the disseminated forms of paracoco, affecting up to 20% of patients. It results primarily from hematogenous dissemination. The most frequently affected bones are the clavicle, ribs, scapula, and sternum. So key points here are this patient had pulmonary lesions, hepatosplenomegaly, diffuse lymph node enlargement, cutaneous lesions, bone lesions. So this is a systemic disease. But epidemiology here is crucial, because if you have all those lesions, and if you live in Brazil, you have to include paracoccidioidomycosis in your differential diagnosis. I want to thank my friends for the help they gave to me. And that's it. Thank you all.
Hello, I'm back. Now, that was an incredible case, just say. Now, I am happy to introduce my friend Angela Atinga. She received her Bachelor of Arts and Medical degree at Cambridge University in England and completed her diagnostic radiology residency at Imperial College in London, followed by 2 years of clinical and research fellowships in MSK radiology at the Joint Department of Medical Imaging in the University of Toronto. She's in her first year as a staff MSK radiologist at Sunnybrook Health Sciences Center and an associate professor in medical imaging at the University of Toronto. She's also a member of the university's Imaging Department Research Committee with a special interest in the application of artificial intelligence and machine learning methods to musculoskeletal radiology. Okay, Angela, the screen is yours.
Thank you. 1 second. Oh, sorry. Okay, you should hopefully see my screen now.
Yes, but it's, oh, okay, now it's good.
Yeah.
Yeah.
Okay. So thank you, Eleni and Hillary, for the kind invitation to share my case with you. I hope you find it interesting. It's definitely not as interesting as Eleni's, but it's just a nice example of a challenging case that I'm sure a lot of us have seen before. So this is the case of a 26-year-old female who presented with a vague history of upper and lower back pain. She had no additional symptoms or history of note. But unfortunately, after her first presentation, she moved away from the city and was lost to follow-up, representing 9 months later with night sweats and weight loss, in addition to her back pain. So at her initial presentation, which is to the emergency department in the middle of the night, she had some radiographs done. These were reported as normal and the patient was discharged. But I think in hindsight, you can see that there is increased sclerosis in the vertebral bodies at the thoracolumbar junction. Her blood work at the time of admission was completely normal. And she also had a chest radiograph at the same visit, which is completely normal. So she comes back 9 months later with this history of constitutional symptoms. And so she's referred for CT imaging of her chest, abdomen, and pelvis, with a primary concern being that of a neoplastic process. The CT shows the sclerotic bone lesions that we noticed on the radiographs. And as you can see that there's some erosion of the T3 vertebral body anteriorly, with some abnormal soft tissue thickening in the paravertebral region. You can also see that there's sclerosis at the thoracolumbar junction. And I hope you can appreciate that there's some epidural soft tissue thickening in, here at T11. No solid organ malignancy or lymphadenopathy was noted. She was discharged from waiting further investigations, but unfortunately presented a few days later after ground level fall. And you can see she's now had a pathologic fracture here at T4. So she's admitted to the hospital for the rest of her investigations. She had a PET CT because we were thinking malignancy at the time, and you can see that all of these lesions were metabolically active. She also had disease there in her sacrum, which I think we didn't really report in the CT. She then went on to have an MRI, and this shows extensive vertebral body involvement with edema at multiple levels. You can see that there is soft tissue thickening anteriorly here, and you've got epidural disease, both in the upper thoracic spine and in the lower thoracic spine. Our differential remained that of an aggressive process, including infection, lymphoproliferative disorder, or maybe metastases from another malignancy. Keeping in mind she had no systemic symptoms at this point. So we proceeded on to a soft tissue biopsy of this paravertebral soft tissue at T2. Samples were sent for culture, including TB, as well as for histology. The results were negative for infection and equivocal for malignancy. But the patient kept having this persistent back pain. She was developing worsening kyphosis in the upper thoracic spine. So the surgical team made a decision to proceed to decompression and debulking with fixation, which happened close to 1 year after her very initial presentation of the back pain. Surgical specimens were sent to for histology and also for microscopy and culture. And this yielded a final diagnosis of tubercular spondylodiscitis. So just to review the pathophysiology of Pott's disease, this is, a lot of the spread is determined by the blood supply to the vertebral body. So remember that arterial supply is via a network of capillaries, which are most prominent anteriorly, with venous drainage most centrally and posteriorly. In pediatric patients, this capillary supply is rich to the end plates and to the intervertebral discs, but these capillaries regress as we age. So in adults, when you get hematogenous spread of infection, you'll get vertebral body involvement predominantly anteriorly with delayed or later disc involvement, and like in children where you get very early end plate and disc involvement and infection. This anterior vertebral body involvement will result in erosions of the vertebral bodies, septic emboli to the few vessels that are there, resulting in end plate infarction and fractures, and loss of vertebral body height, which will predominate anteriorly. So if you look at our imaging findings, that's exactly what we had. We had anterior vertebral body erosion involving the end plates, and then we had progressive vertebral body height loss. You can see that the disc spaces are relatively spared. On the STIR image here, you've got no increased signal in the intervertebral discs, but you do have this subligamentous spread of infection anteriorly, and then you've got the epidural disease posteriorly. The patient didn't have conscious, as this was done as an emergency to assess for cord compression. So it's unclear if there was any true abscess in this phlegmon here. The question remains, in imaging, can you tell between pyogenic and tuberculous infection? And there are multiple papers that have been published about this. So if you think about this in three ways, there's a clinical presentation, and the theory is that in pyogenic infections, you get acute or subacute presentations with pain and fever, versus tuberculous infection, which will be more indolent with constitutional symptoms and maybe a vague history of back pain, like in our patient. If you think about the spread of infection, it's hematogenous in both, but in pyogenic infections, we also think about direct spread, for example, in patients who've had surgical intervention. And then when you look at the imaging, bone marrow edema exists in both, and you'll have enhancement of the vertebral bodies. But in TB, you're thinking more of that anterior involvement with relative sparing of the rest of the vertebral body, at least early on in disease. In pyogenic infection, we see a lot of high T2 signal in the disc, whereas in TB, we would think about the disc being relatively spared, but with more subligamentous soft tissue disease extension. And then you also think about the epidural or paravertebral soft tissue disease. So you'll get paravertebral abscesses, which we had in our patient, which we had paravertebral soft tissue in our patient. You'll get more abscesses in pyogenic infections. In TB, you think about the cold abscess, so very, very large paraspinal or paravertebral abscesses, but with very little systemic symptoms. And sometimes you might see calcification, which tells you this is a long, kind of protracted process. In reality, of course, these distinctions are very difficult to make purely in clinical or imaging findings, particularly very early on in disease. And so we've seen an increasing move towards spinal biopsies and aspiration, keeping in mind that the diagnostic yield of these isn't very high. So the literature quotes between 30 to 40% in a single biopsy, and often patients will have repeat biopsies or surgical excision or debulking, such as in our case. So here's an example of pyogenic infection. This is from a patient I saw last week, and you can see that there is diffuse vertebral body edema at L3 and L4. You can see high signal intensity in the intervening disc, and you can see that there's phlegmonous tissue both anteriorly and posteriorly, with extensive enhancement of the anterior epidural soft tissues on the post-contrast T1 imaging. On the axial sequences, you can see that this patient also has phlegmonous enhancement of the psoas muscles and paravertebral soft tissues, which is thought to be quite a sensitive sign for infection. And you can see that there's a small micro abscess in the left psoas muscle. Just to show you some of the other differential diagnoses that we considered. So we wondered whether this patient maybe had LCH. And here's an MR example of a patient with LCH from one of our institutions here in Toronto. You can see that there is edema within the vertebral bodies, and then you've got vertebroplanar. I think this was at L1, and you've got that kyphosis developing with subligamentous soft tissue anteriorly and epidural soft tissue posteriorly. This is a different patient from the literature, and you can see that this patient has vertebroplanar with some sclerosis. LCH, of course, is in our differential diagnosis, but there are a few problems. For example, this patient is a little bit too old. Classically, LCH is thought to be a disease of the young teenager or the child, and this patient was 26. All of her lesions were sclerotic, so there's no lesion that showed any lytic process, which is more common with LCH. And she didn't have any involvement of her, calvarium or appendicular skeleton. But again, LCH can look like anything, so we included it in the differential. This is a patient from our institution with lymphoma, and you can see that they had sclerotic vertebral bodies with some erosion, very similar to a case. The soft tissue windows would have shown you that this patient had a little bit of both epidural and anterior perivertebral soft tissue. So I think lymphoma is a reasonable consideration. We also thought about metastases in this patient who had no history of infection or constitutional symptoms. And so here's an example of a patient with breast cancer with multifocal osteoblastic metastases and vertebral body sclerosis. And you can see pathologic fractures at the thoracolumbar junction. So again, I think our differential diagnoses were within sort of what you'd expect. So I thought this was a nice case to present because it's a very classically challenging case of Pott's disease, as the books say. You get the classic vague history and symptoms of insidious back pain, very slow progression, quite a long history. Her imaging was very classic with the anterior end plate involvement, that gibbous deformity, preservation of the disc spaces with the subligamentous spread. Although in her case, it was very interesting that she had paravertebral soft tissue, but not big collections, and she had no evidence at all of pulmonary disease, which only developed after she'd started treatment for TB. And then we've gone through some examples of the differential diagnoses that we'd considered. I've just included some other things that we thought about, which are atypical infections, such as brucella and fungal infections. We thought about Gorham-Stout's disease or vanishing bone disease, just because we see a lot of them in Toronto, but the imaging looked pretty different to what's in the books. So I guess the final question remained for us, even after all of this, is that TB is not considered to be endemic in Canada. So it's like, how did she develop this infection? And so further investigation and questioning by the clinicians clinched this for us. Turns out that the patient had a household contact who'd recently traveled abroad to a TB endemic area, had subclinical active TB infection, and that's how she contacted the disease. And while she was being treated, her household member also became unwell. Thank you so much for your attention, and you can contact me if you'd like to.
Hi again. Wow, Angela, that was a beautiful case, a great review. Now I have the pleasure of introducing another friend. Dr. Dorota Linda is a fellow of the Royal College of Physicians of Canada and an assistant professor of medical imaging at the University of Toronto. Her clinical work focuses on multimodality imaging of musculoskeletal disorders, including bone and soft tissue tumors, rheumatologic diseases, and sports injuries. She is a certified clinical densitometrist from the International Society for Clinical Densitometry. She completed medical school at the University of Manitoba, diagnostic radiology residency at McMaster University, and fellowship in musculoskeletal imaging at the University of California in San Diego. Outside of the hospital, Dr. Linda loves to lift weights, travel, snowboard, hike challenging terrain, road cycle, bake sourdough, and express her creativity through interior design and painting. That's very interesting. Okay, Dorota. Sherry.
Thank you, Hillary, for that introduction. I will share my screen.
I think, Angela, you first have to unshare yours so Dorota can share hers. Angela? Yeah, thank you. Dorota, see if you can share your screen now. Yeah, good.
Can you see that?
Yeah.
Okay, perfect.
But it's not in presentation mode. Okay, now it's good. Thank you.
Okay, so just want to say thank you to Eleni and Hillary for inviting me to present an infection case. My case today is of a 53-year-old male who developed a superficial wound at the dorsal aspect of his fourth finger. Once the eschar fell off, this lesion started growing substantially. And it is at this point that he presented to the emergency department. Now, I've strategically redacted a small detail of the clinical history just to maintain the suspense. On examination, he was well. He had no fever, no other constitutional symptoms. His hand exam revealed a very large fungating mass at the dorsal aspect of the ring finger. He was right hand dominant. This was on his left hand. He had no pain, full range of motion. His distal sensation was intact. He didn't have any bleeding locally at the site, and there was no purulent discharge. His past medical history was complicated. He had multi-organ transplants 6 months prior to presentation. He had a liver transplant for cirrhosis, which was due to hepatitis C virus and hepatocellular carcinoma. He had a kidney transplant for end-stage renal disease due to obstructive uropathy and staghorn calculi, as well as diabetic nephropathy. And his past medical history was also positive for type 2 diabetes, hypertension, latent tuberculosis infection, for which he undergone 9 months of treatment with isoniazid, severe aortic stenosis, and mitral stenosis. He was on over a dozen different medications, but the relevant medications relate to his immunosuppression, and they were tacrolimus, prednisone, and mycophenolate, Mofetil. On radiographs, he had a large lobulated soft tissue mass that was at the dorsal aspect of his left fourth digit. There was no internal mineralization or ossification within the lesion. There was no involvement on the underlying bones, no periostitis, and no osseous destruction to suggest osteomyelitis radiographically. He did have extensive vascular calcification related to his systemic diseases, as well as an oval calcified lesion at the volar aspect of the distal forearm, consistent with an AV fistula that was used for prior dialysis. MRI confirmed the large lobulated mass at the dorsal aspect of the fourth digit. It was iso-intense to muscle on T1 weighted imaging and heterogeneous, but predominantly hyperintense on T2 weighted fat saturated imaging. Following the administration of gadolinium contrast, there was avid enhancement with this sort of radial papillary or frond-like pattern. There was edema deep to the lesion, but there was no alteration in the bone marrow signal intensity to suggest any osseous involvement or any osteomyelitis. So the differential diagnosis at this point was infection, some sort of unusual infection, but we could not rule out a malignancy. So just when looking at, for example, benign soft tissue tumors in a very large referral population and the distribution by anatomic location and age, for a 53-year-old individual in the hand and wrist, the top 3 most frequent lesions are giant cell tumor of the tendon sheath, fibrous histiocytoma, and hemangioma, followed by lipoma, chondroma, and fibromatosis. For malignant lesions, the top 3 most frequent tumors in the hand and wrist in a patient that was 53 years old is MFH, which is now UPS or undifferentiated pleomorphic sarcoma, synovial sarcoma, and fibrosarcoma, followed by epithelioid sarcoma and liposarcoma. I think the imaging in this patient did not have any characteristic features that would specifically fit any tumor diagnosis. So the plan was consultation with plastic surgery and biopsy of this soft tissue mass of the digit. The biopsy revealed necrotic skin with bacterial overgrowth. It was negative for malignancy. GMS and PS stains, which are special stains for fungal organisms, were negative. Acid-fast bacilli, negative. The biopsy did show mixed gram-negative and gram-positive bacteria. Microbiologic culture grew methicillin-sensitive Staph aureus, Morganella, and Pseudomonas. So the patient was discharged on clavulin, but because there was no superinfection with bacteria, the antibiotics were ultimately discontinued. In conjunction with the multi-organ transplant team, his immunosuppression was decreased in an effort to curtail the growth of this lesion. But despite the immunosuppression reduction, this lesion continued to grow quite rapidly. So at this point, the decision was made to intervene surgically, and the patient was offered two different procedures: a digit sparing procedure, which would require graft harvest from another donor site and may have resulted in stiffness and extended rehabilitation period, or alternatively amputation of the digit with a smaller incision, significantly less downtime, and less risk of potential recurrence. And it's this latter option that the patient opted for and had an amputation of the fourth digit to the level of the metacarpal with some multiligamentous reconstruction. So the amputation specimen was sent for pathology, and it revealed skin with virocytoplasmic effect, necrosis, and abundant granulation tissue. Under electron microscopy, there was visualization of viral particles. The sample was also sent to the National Microbiology Laboratory in Winnipeg in central Canada, where PCR is available, and quantitative PCR was positive for parapoxvirus. And using a special sequencing method called Sanger, it confirmed this to be ORF virus. So going back to our clinical history and that small piece of history that I redacted initially, 2 weeks prior to his presentation in the emergency room, the patient had actually visited a farm and was bitten by a sheep to that hand, involving the fourth digit. So this is a case of ORF virus infection involving the hand following a sheep bite in an immunocompromised individual. So ORF virus is also called ecthyma contagiosum, contagious pustular dermatitis, and labial dermatitis. And it's a virus that's endemic to sheep and goat herds worldwide, but also seen in other ruminant animals. It's a highly contagious virus, so within a herd, multiple sheep can be infected, and they develop characteristic skin lesions on their lips, muzzle, ears, eyelids, and nostrils. It's relatively common in ranching communities as well as in individuals who process these animals for human consumption. In the immunocompetent patient, so typically this disease is self-limited and there's a spontaneous resolution in 4 to 8 weeks after it goes through a very characteristic set of phases shown in these 3 pictures. So the first picture shows sort of a papular phase, followed by a target lesion, and then a regenerative phase where there's a central crust that develops. So ORF virus is a parapox virus, and it's in the family Poxviridae. This is double-stranded DNA virus and some of the largest of all animal viruses. It's transmitted by direct contact inoculation. So as in our case, a direct bite by the sheep of the hand. So there's a wound in the skin, but it can also be spread by contaminated fomites. The frequency is largely unknown because most infections go unreported. Patients develop a lesion following a very typical history, and there's spontaneous resolution, and they don't really seek treatment. There is a sex predilection. More males than females develop this disease, and that's because of an occupational bias. And adults are more likely to get this disease than children, but pediatric cases have been reported in the setting of petting zoos and farm visits. There is an occupational hazard for ranchers, veterinarians, butchers, sheep shearers, as well as shepherds. So typically in the immunocompetent patient, the prognosis is excellent. Patients have complete healing of these lesions with no scarring in just over a month. Some of the complications include fever, lymphangitis, lymphadenopathy, erythema multiforme, and these lesions can become superinfected with bacteria. This is not the case in the immunocompromised patient, where lesions can be progressive, destructive. Patients can develop giant ORF, multiple lesions, and recurrent lesions. They may need to have antiviral therapy. Their immunosuppression may need to be reduced. Surgical debridement is considered a treatment option. And then in the case of our patient, amputation is also a consideration in cases that are refractory to other treatments. So there's very few cases of ORF that has been described in the literature. They're mainly in the immunocompromised individual. I found no cases in the literature that had imaging correlation. Here are some of the cases, individual cases that I found. This was a 65-year-old male who had a base of skull infiltrating lymphocytic lymphoma. He cut his middle finger cleaning out a sheep's head, developed a lesion. There was no spontaneous resolution, and ultimately had to undergo amputation. Here's a 55-year-old male that had chronic lymphocytic leukemia. He was shearing his sheep, developed a lesion more on the palmar aspect of the hand. Again, this did not spontaneously resolve and ended up having to be excised. And another case of a 34-year-old male with chronic mucocutaneous candidiasis, an inborn error of interleukin-17 immunity. He injured his hand during a lamb sacrifice during a Muslim holiday, developed a very large lesion involving the dorsal aspect of the hand without spontaneous resolution, and ultimately had successful treatment with IV antiviral therapy. This is a patient, this is a paper, sorry for the overlay there. This is a paper that was published in the dermatology literature describing giant progressive and destructive ORF infection. They had several patients that had these unusually large progressive lesions with uncontrolled growth, and they termed the disease ORF progressiva. These lesions recurred following excision, and ultimately patients had successful medical therapy, avoiding surgery and potentially mutilating surgery. So all these lesions clinically sort of resemble a cauliflower-like growth. And I think our MR imaging nicely correlates with that, with these frond-like areas and papillary projections on the post-gadolinium MRI. So back to our patient, his post-operative course was relatively uneventful. On clinical follow-up, he was well. The wound post-amputation had healed nicely. There was no pain or discharge. He had no signs or symptoms of infection, and he was completing home-based range of motion exercises to improve the function of his left hand. So thank you very much. This is some of the ways that you can get in touch with me. So feel free to email me or message me if you have any questions or comments.
Thank you, Dorota. Wonderful case. I have never seen this in Brazil. So now it's my pleasure to introduce my good friend, Dr. Sérgio Viana. He is a practicing radiologist at Hospital da Criança de Brasília. which can be translated as Child Hospital in Brasilia, which is the capital of Brazil. Also, he works at Tesla Diagnóstico por Imagem and Diagnóstico Imagens Médicas, all in Brasilia. And he is a full member of the ISS. He co-authored books, book chapters, and several articles in the field of MSK imaging, also being actively involved in continued medical education on his platform, which is called Advanced MSK. You can find him on YouTube. He has a YouTube channel called Advanced MSK. He's also on Instagram, and I think that's it. He can correct me if I'm wrong. So please, Sergio in Portuguese, Sergio in English, take it away.
Thank you very much, Eleni. Let me share my screen. Just 1 second. Okay, can you see my screen?
Yeah.
Okay. First, thank you very much for your kind introduction. Thank you once again for the kind invitation. It's a real pleasure to be here again. Today, we're gonna talk about the case of a 12-year-old boy with left-sided pain and swelling on the sternoclavicular joint for, 4 weeks. He had fever, leukocytosis, and raised inflammatory markers. There was no trauma, and his previous medical history was irrelevant. Here we have an AP view of the left clavicle. There is a periosteal reaction along the shaft of this bone, and apparently there is also a bone, an area of bone destruction on the medial third of the clavicle. These coronal MRI images are very adequate to show that this the lesion really exists. It presents a heterogeneous signal intensity on T1 weighted images and predominantly high signal intensity on fat set T2 weighted images. There was also bone marrow edema and edema of the surrounding soft tissues. The axial plane is appropriate to show this area of cortical discontinuity, anterior cortical discontinuity adjacent to the lesion. After injection of contrast, there was enhancement, a thick rind of enhancement surrounding a central area of absent enhancement. And these axial stir images, comparative images, show the presence of edema of the surrounding soft tissues on the left side, in addition to the bone lesion itself. CT images are very adequate to demonstrate the areas of bone discontinuity of these areas of cortical break, in addition to a periosteal reaction, bone neoformation, and there are also tiny foci within the lesion which are compatible with sequestra. The lesion is filled with fluid, and this patient was submitted to aspiration, to biopsy and aspiration, and the material was compatible with staphylococcal osteomyelitis. So what's the big deal? Why is this relevant? First, bacterial osteomyelitis of the clavicle is an unusual occurrence. It responds for less than 3% of all cases of osteomyelitis in children, usually hematogenic and caused by Staphylococcus aureus. It may develop in any portion of the bone, and involvement of the medial third is not uncommon, mostly in children. Differential diagnosis is vast and includes soft tissue infection, fracture, sternoclavicular arthritis, osteonecrosis, tumor and tumor-like conditions, and mostly non-bacterial osteitis, which is widely known as chronic recurrent multifocal osteomyelitis, or CRMO. And despite its relative rarity, CRMO is the most common non-neoplastic lesion of the clavicle in the first 2 decades of life. And overall, the most common lesion of the medial third of the clavicle across all age groups. So if an expansile lesion is found in the medial clavicle, sparing the sternoclavicular joint in children and adolescents, it should be considered CRMO until proven otherwise. So from an imaging standpoint, how can we tell one condition from another? Bone and soft tissue abscesses and sequestra are absent in CRMO and are typical for bacterial osteomyelitis. And biopsies are non-diagnostic in CRMO. They show only non-specific osseous inflammation. In CRMO, we typically find an osteolytic expansile lesion typically affecting the medial extremity of the clavicle that may simulate an aggressive process with osteitis, periosteal reaction, including the onion skin type. Soft tissue component is usually present, and concomitant sclerosis and hyperostosis can be seen in cases of chronic evolution or long-standing cases. Unlike in Sapho syndrome, we have no involvement of the surrounding structures. So the sternoclavicular joint, the anterior portion of the ribs, and the manubrium are typically spared, with no signs of sternoclavicular arthritis or costoclavicular enthesopathy. In CRMO, isolated involvement of the clavicle, when typical, has the same meaning as multifocal involvement as a diagnostic criterion, since CRMO is typically a multifocal disease, but the involvement of the medial third is so typical that is considered diagnostic. So we're gonna show some cases of CRMO. This is a typical case of 14-year-old male. We can see a destructive lesion involving the medial third of the clavicle. There is periosteal reaction, lamellated of the onion skin type. The MRI images show bone marrow edema, osteitis, surrounded by edema of the soft tissues with post-contrast enhancement due to active inflammation. Another case, a 16-year-old male. We can see a destructive lesion once again in the medial third of the clavicle, the left clavicle. On reformatted images, we can see the normal side. We can see the affected side. Once again, destructive lesion affecting the medial third of the clavicle with periosteal reaction with bone neoformation. And note in these images that there is a cortical thickening, that there is bone expansion and narrowing of the medullary canal compared with the contralateral clavicle. This is typical for hyperostosis. This is indicative of a more chronic process, of a long-standing process. And finally, this 9-year-old female, she sought medical attention because of this lump. We can see in this three-dimensional reconstruction, there is a lump over the medial third of the left clavicle. Once again, an aggressive appearing lesion with bone destruction, with periosteal reaction, without involvement of the sternoclavicular joint. Note that the lesion only involves, is confined to the medial third of the clavicle and leads to bulging of the skin surface. That was the cause of the main complaint of this child. So in conclusion, osteomyelitis of the clavicle is quite rare, but it does occur, and robust hypothesis can be suggested on imaging if typical findings are present, which are abscesses, sequestra, and/or fistulous tracts in a compatible clinical picture. However, even though CRMO is not exactly frequent, we know for a fact that it is largely underdiagnosed, and it's a far more common diagnosis if a destructive lesion is present in the medial third of the clavicle, often presenting an aggressive appearance on imaging. It is the most likely diagnosis in patients under 20 with comparable imaging findings. So the take-home message is that awareness of both entities and of the clinical and imaging differences between them is crucial to a correct diagnosis and adequate management. So this is it. Thank you very much for your attention.
Thank you, Sergio. Beautiful, as usual. What is this city, Brasilia? The one you showed in the last slide?
Yes. Let me show you once again.
It's the capital of Brazil.
Here you can see the planet, the appearance of the city. It's like an airplane. This is the north wing. This is the south wing. This is the esplanade of the ministries. This is the seat of where the president, the office of the president, our White House, and this is the rest of the cabin of the plane. So this is the planet area of the city. These are the outskirts are here, and this is the Paranoa Lake. That is an artificial lake that was man-made for the construction of the city.
Thank you. Although I'm Brazilian, I have never saw Brasilia from this point.
from above, yes.
Yeah. Okay, so let's see if we have questions here. There was one question that Angela already answered. So someone asked, this patient has no signs of TB lung disease, and she said none, completely normal chest x-ray, and only developed effusions and chest disease after starting TB therapy. Great and kind of unusual cases. Thanks for sharing. And I don't see any questions. So I want to give one information from my case. So paracoccidioidomycosis is more common in South America, and it's in Brazil we have 80% of the cases of all South America, so it's very common here. So that's why we have always to have this diagnosis in mind. So okay, thank you all for joining us today. Our next session will be held on June 24, and it will focus on major trauma. See you there. Bye-bye.